Hello, one and all. Today, it's my great pleasure to introduce today's NICER Education Camp. My name's Paul Gallo. I'm a pediatric hematologist at Children's Hospital, Colorado. Today's education camp is on trisomy 21 and immune dysregulation. The first speaker for today is Dr. Michele Lambert. Dr. Lambert is an associate professor of pediatrics in the section of hematology at Children's Hospital, Philadelphia. She's also a member of the Disorders of Immune Regulation Consult Service there. She's a founding member of the Pediatric ITP Consortium and has extensive experience managing the hematologic and immunologic manifestations of trisomy 21. Today, she will be giving her talk, Understanding Cytopenias in Trisomy 21. And as a former mentee of Dr. Lambert, it is my great pleasure to introduce her to give her talk on the cytopenias in Trisomy 21.
Good morning, everybody, and thank you for joining us for this education consortium. I'm going to talk about the approach to hematologic abnormalities in trisomy 21. And I want to thank the organizers for the invitation to speak today. And with that, we'll get started. These are my disclosures. None of these are really that relevant to trisomy 21 specifically. But the most important thing, I think, is that our own local expert here in this disorder is actually Kaoru Takasaki, who is not giving this talk, but I want to acknowledge her and thank her for her help with putting together these slides and making sure that I am giving all of the correct information. So our objectives today are to develop a systematic approach to various hematologic abnormalities in patients with trisomy 21 and to recognize the impact of patient clinical characteristics on our diagnostic evaluation. We all know that trisomy 21 is one of the most common chromosomal abnormalities that we see. It affects about 1 in 700 births. And this translates to about 6,000 infants each year in the US who are born with Down syndrome. The risk of having an infant with trisomy 21 increases with maternal age, so that if you're over 35, you have a significantly higher risk. Hematologic abnormalities are very prevalent in this population. And so it's really important for us as hemonc practitioners and immunologists who look at CBCs regularly to understand what's normal and what's not normal. And we also know that the risk of hematologic malignancy is much higher in patients with trisomy 21 than in the general population. And that's going to be our next talk. So why do we know so much about hematologic abnormalities in trisomy 21? One of the biggest reasons is that the current guidelines recommend a CBC at birth and then routine monitoring of CBCs for children with trisomy 21 at least every year, depending on exactly what's seen on those CBCs. And so for that reason, we have significantly more CBCs during all of childhood for children who have trisomy 21 and a much more granular understanding of changes in counts over time. And I think because of that, we're used to seeing some of these differences, but it also means that we have a lot more data with which to potentially fall down a rabbit hole. So let's talk about children with trisomy 21 and changes in their CBCs. And let's talk about that by breaking it up into in the neonatal period and then later on in childhood. We commonly see changes in all three cell lines in neonates who have trisomy 21. 80% of the time neutrophils were increased, and this is a study that looked at 158 infants across multiple different hospitals in the newborn period, which was defined as the first 3 weeks of life. So 80% of the neutrophils were increased, and only 4% of the neutrophils were decreased, with only one child with an ANC that was less than 1,000. And so really neutrophilia is quite common in neonates with trisomy 21. And it's important to understand that that's true and not necessarily panic with an elevated neutrophil count or specifically worry about things like infection, although it can mask infection. So we have to be vigilant. Thrombocytopenia was the next most common abnormality in the CBCs, and about 66% of the CBCs had platelet counts that were outside the reference range of less than 150, with 33% of those being between 101 to 149, 27% being between 50 and 100,000, and only 6%, so less than 10% of patients had severe thrombocytopenia with a platelet count of less than 50,000. So I think it's important, if you have severe thrombocytopenia in a neonate with trisomy 21, to think about potentially other reasons for that thrombocytopenia. And one of the most important things to really think about are things like infection and NEC in this patient population when we see that kind of thrombocytopenia. But more mild thrombocytopenia is really quite common, quite prevalent, and it is important to recognize that. What's also interesting is that the mean platelet volume in most patients who have thrombocytopenia is inversely correlated to the platelet count. So the lower the platelet count, the higher the mean platelet volume most of the time. But in neonates with trisomy 21 with thrombocytopenia, the MPV did not correlate with the platelet count and was noted in general to be a little bit increased. And then the last thing that we look at is the red cells. And in patients with trisomy 21, we see polycythemia pretty commonly with hematocrits that are over 65% or hemoglobin's over 22 in a third of neonates with Down syndrome. And 14% of patients had hemoglobins that were even higher, above 23, with 70% or higher hematocrit. So I think it's really important to recognize that this is an abnormality that we see quite commonly in neonates. And I think we see this a little bit more than we used to see it with delayed cord clamping in all children, but this is particularly prevalent among the neonates with trisomy 21. The other important thing to note is that children who had thrombocytopenia were more likely to have polycythemia with an odds ratio of 3.39. And so if you have one abnormality, it doesn't necessarily follow that you'll have a second one, but if that first abnormality is thrombocytopenia, then you are more likely to have polycythemia in the neonatal period. So the current recommendations are to obtain a CBC with a differential by 3 days of life in all children with Down syndrome or trisomy 21. And this is really to evaluate for transient abnormal myelopoiesis, or TAM. This was formerly called transient myeloproliferative disorder or transient leukemia. And now we call it TAM. And because hematologic abnormalities are so prevalent in the first couple of weeks of life in children with Down syndrome, this first CBC is really to establish what do things look like and to let us know whether or not we need to continue to follow that CBC much more closely, or can we just repeat the next one at a month and then the next one again at a year of age. TAM is defined as blasts on the smear in an infant with trisomy 21, and about 10% of infants will have TAM. And this is because many of the children will have an acquired mutation in GATA1 that results in the production of GATA1 short. This GATA1 short is associated with the blast count, and having a blast count over 10% is highly suggestive of having a change in GATA1, this GATA1 short. And having blasts of over 20% is universally associated with GATA1 short. But because it's difficult to get this testing, the GATA1 short mutation testing, in all hospitals, in general, if children have blasts on their smear, then they're monitored and treated as a TAM patient. Children who have less than 10% blasts may have silent TAM and have the GATA1 short mutation. Their risk of malignancy seems to be lower than those who have more overt TAM and greater than 20% blasts, but it's still higher than in a child who doesn't have TAM at all with trisomy 21. And so it's important to recognize that these differences in risk exist, but if there are blasts on the smear, we observe with serial CBCs, and those serial CBCs should be done at least every 3 months for up to 4 years, but at least the first 2 years of life. And then maybe if they've been completely normal and no further blasts, you could space out potentially to every 6 months between 2 and 4 years of age, but really need to be followed very closely in the first 4 years of life because of the risk of developing malignancy. So treatment of TAM, as I just said, is mostly observation. I mean, most children don't need to get actual treatment for the transient abnormal myelopoiesis. But there are some children who require treatment because their abnormal myelopoiesis is actually starting to cause problems. So if the white count is very high, if there's eye drops, if they have DIC with coagulopathy and bleeding symptoms as a result of having this abnormal myelopoiesis, if they have hepatopathy, particularly if the bilirubin is significantly increased, or if there's ascites, most of the recommendations are to treat, and the treatment is with low-dose cytarabine, which really seems to be quite effective in these patients. In general, if you think a patient is going to be headed towards severe TAM, it's better to intervene early than to wait for a long time and have that patient continue to get sicker and sicker. Okay, so that's neonates with trisomy 21. What about in older children? Well, we know that children with trisomy 21 are much more likely to have macrocytosis, and there's separate curves that have been developed by Dr. Grinberg and colleagues, most recently published in JPHO, that really demonstrate this increase in MCV very nicely, and it's true for both male and female patients, and the MCV can be quite high. What's important about recognizing this macrocytosis is that this macrocytosis not only sometimes causes stress and distress to families who are not familiar with trisomy 21 and worry about this being a sign that there's something going on, but it also can mask more common problems that are seen in childhood in anybody, such as iron deficiency. And most children who are iron deficient with trisomy 21 do not have microcytosis. They have a normal MCV or maybe even still are a little bit macrocytic. So this is important to keep in mind, particularly if you have a normocytic anemia in a child with trisomy 21. That child really needs to be screened for iron deficiency. And hemoglobins tend to be higher in children with trisomy 21, and they have a bit of a polycythemia that begins in the neonatal period and really lasts throughout all of childhood and into adulthood. And so again, this can mask iron deficiency if we're not screening separately for iron deficiency by looking at levels of ferritin and iron. It's important to keep in mind that a child with trisomy 21 may have a completely normal hemoglobin and still be iron deficient. If their baseline hemoglobin really is 13 and they get down to 11, that child probably has iron deficiency anemia, not just iron deficiency. So it's important to keep these things in mind and to really consider these things when we're evaluating a CBC in a child with trisomy 21. And then another important thing to keep in mind are that the lymphocyte counts are also lower. And so in children with Down syndrome, they can have lymphopenia, and this may be related to the immune deficiency that we'll also talk about a little bit later. And so I think keeping in mind the total CBC and the total picture of the patient is really important. And then what about things like neutropenia and thrombocytopenia? Well, children with trisomy 21 can have transient neutropenia and thrombocytopenia, particularly with intercurrent illness, and they seem to be especially susceptible to having abnormal blood counts with thrombocytopenia, especially, and neutropenia in the setting of severe illness. And this thrombocytopenia and neutropenia is associated with worse outcomes in children who are severely ill with trisomy 21. So we can see these transient drops in counts in the setting of being sick and they may be a marker of severe illness and of the fact that that patient is at risk for getting sicker before they get better. And then finally, the immune deficiency that is associated with trisomy 21 increases the risk of autoimmune cytopenias, and particularly we see ITP in this patient population. This becomes complicated because persistent thrombocytopenia also makes us worry about the development of malignancy in this patient. And so it's important to really monitor these children closely. And unlike other children with sudden onset severe thrombocytopenia, in the absence of other hematologic abnormalities, children with Down syndrome really deserve consideration of a marrow early in the course of their disease, rather than waiting until that thrombocytopenia has been persistent for months and months. And just because it's my favorite disorder to talk about, I do want to take a minute to talk about immune thrombocytopenia in this patient population. We manage autoimmune cytopenias in trisomy 21 similarly to the way that we manage them in children who do not have trisomy 21. But it's important to keep in mind that patients with trisomy 21 were excluded from the initial therapeutic trials of things like the thrombopoietin receptor agonists, which are really becoming a mainstay for the treatment of pediatric ITP. So there's no published studies of TPO receptor agonists in trisomy 21. And for that matter, there's no cohort studies describing the use of TPO-RA in autoimmune cytopenias in trisomy 21. And so I think it's really, really important to think about that and to really understand what the potential risk might be, because the thrombopoietin receptor agonists, while they primarily target megakaryocytes, thrombopoietin is also expressed on hematopoietic stem cells. And this is why we see in children who are treated with a TPO receptor agonist that they may have an increase in white blood cell count, they may have a leukocytosis, and they may have polycythemia, or at least an increase in hemoglobin, in the absence of trisomy 21 with the treatment with a TPO-RA. And then when we combine that then with underlying Down syndrome, we may see significant abnormalities in the counts. And this might even prompt us to get a bone marrow examination in a child with trisomy 21 if we choose to use a TPO-RA in that setting. So I think it's important to keep that in mind and to counsel families about the risk. We don't know if the TPO-RAs are going to increase the risk for development of malignancy by driving potentially an abnormal stem cell clone. And so it's really important to kind of keep that in mind. Doesn't necessarily mean we wouldn't use the TPO-RAs, but we might think about duration and dose in this patient population a little bit differently. And what I found in my own clinical practice is that rituximab seems to be particularly effective in this patient population. They really do seem to have abnormal antibody production that results in the development of ITP. But it does carry a higher risk for persistent hypogammaglobulinemia post-administration. So it's important to counsel families about that and to monitor for the development of hypogam post-administration of rituximab, which we should be doing in everybody, but particularly paying attention when that patient has Down syndrome and we've given them rituximab. Particularly if we need to give extra doses of the rituximab in this clinical setting. So to sort of summarize my approach to hematologic abnormalities in children with trisomy 21, I first separate out whether or not we're talking about in the neonatal period or we're talking about older children, and then look at the different blood cell counts. So if you have thrombocytopenia or leukocytosis in a neonate, I really separate it by whether or not they have blasts. And if they have blasts, then I really think about them as a TAM patient. Honestly, at our institution, those patients get followed mostly by our oncology service, and I'm kind of off the hook. But in our patients who don't have blasts, who develop thrombocytopenia, if that thrombocytopenia is severe, I really think about other reasons for that platelet count to be low, because it's okay for it to be a little bit low, but if it's severely low, less than 50,000, have to think about other reasons for thrombocytopenia. And polycythemia is pretty common, and I don't worry too much about that. In older children, because the polycythemia and macrocytosis, that's baseline for them, this can hide things like iron deficiency and iron deficiency anemia, and it's important to consider screening for those things with other tests like a ferritin and an iron in order to understand what the patient's true iron balance is. Thrombocytopenia is also common in older children and typically is transient, and we'll just monitor that. But they are at increased risk of developing ITP. And if they have prolonged or persistent thrombocytopenia, especially if they're not responding to ITP therapies, I really worry that that patient is developing malignancy and will pretty quickly move to doing a bone marrow examination. And the last thing to think about with cythemia and macrocytosis is if you have really significant polycythemia, they can have mild polycythemia at baseline, but if it's significant, remember that these patients are also at risk for obstructive sleep apnea because of their hypotonia and other abnormalities. And so it's important to consider that and make your referral to your local friendly pulmonologist to get that evaluated. So to summarize my approach and the findings that we see, hematologic changes are really common in children with trisomy 21. It's important to recognize expected changes versus true pathology and to understand exactly how those expected changes might mask other underlying hematologic problems. Thrombocytopenia is frequent, it's usually transient, and it's not usually severe. So when it's severe, we have to think about other reasons for that thrombocytopenia. Persistent thrombocytopenia or neutropenia really requires bone marrow evaluation in this patient population, and especially if you have multiple cytopenias, really have to think about doing a bone marrow. Management of the immune cytopenias is similar to patients without Down syndrome, with the caveat that data are very limited for all of our therapies that's specific to this patient population. So we need to be a little bit careful, a little bit cautious about the things that we do, and remember how that might impact a potentially abnormal bone marrow. And with that, I'd really like to acknowledge Kaoru Takasaki, who helped put together these slides and also is our local expert and the person that I go to whenever I have questions about my patients with trisomy 21. And also our platelet disorder team and our immune dysregulation team and those institutions and organizations that have helped by providing funding for research projects and other things. And with that, I'm really happy to have been invited to give this talk, and I thank you for your attention.
Good morning, everybody. I'm Dr. Kevin Lewis, Pediatric Hematology Oncology Fellow from the University of Michigan, and it's my pleasure to welcome our next speaker, Dr. Jason Berman, who is a full-time professor of pediatrics in cellular and molecular medicine at the University of Ottawa. He did his initial training in Toronto, both for medical school and for residency in pediatrics at the Hospital for Sick Children in Toronto. And then he came to the US to do his fellowship training at Boston Children's Hospital in pediatric hematology oncology, and then did his postdoc in molecular oncology at Dana-Farber Cancer Institute. He has extensive clinical and research experience in leukemia and specifically with patients with Down syndrome. His clinical experience with children with Down syndrome and leukemia is in so much that he served as the co-chair of the first international trial of risk-stratified therapy in Down syndrome myeloid leukemia. As far as his research experience in the field goes, he built an internationally recognized center of research excellence using zebrafish as a preclinical model of childhood cancers and rare genetic disorders. And then in 2019, he joined the Children's Hospital of Eastern Ontario, where he serves as the CEO and scientific director of the Research Institute and vice president of research. He also is the founding member of the Canadian Rare Disease Models and Mechanisms Network and is the director on the board of the International Zebrafish Disease Modeling Society. As far as other roles that he holds with regards to leukemia, he is the chair of the Medical Scientific Committee of the Leukemia Lymphoma Society of Canada. Additionally, he was awarded the King Charles III Coronation Medal by the Minister of Health and Deputy Premier of Ontario this past year. It's my pleasure to welcome Dr. Jason Berman to talk now about hematologic malignancies and trisomy 21.
Hello, everyone. I'm delighted to be with you today and want to thank the organizers for inviting me here to present to you My name is Jason Berman, and I'm coming to you from Ottawa, Canada, and I'm looking forward to chatting with you today about hematologic malignancies in trisomy 21, or Down syndrome. To begin with an introduction to Down syndrome, and as I think everyone knows, it's the most common chromosomal condition that we see. It has a prevalence of 1 in 700 live births, and as can be seen by the photograph on the right, clinical features include specific facial morphology, developmental delay, hypotonia, and an increased risk of a number of developmental abnormalities, including leukemia, which is the topic for today. Down syndrome is caused by trisomy 21, and here's a karyotype which illustrates the 3 chromosome 21s. And having trisomy 21 causes unique predisposition to both transient abnormal myelopoiesis, or TAM, and the myeloid leukemia of Down syndrome. So that's the focus of today's discussion. The WHO defines the myeloid leukemia associated with Down syndrome as MLDS. This was previously had other names, but this is the official WHO definition. And the official WHO term is TAM, or transient abnormal myelopoiesis, also known as transient myeloproliferative disorder, TMD, or transient leukemia. So MLDS, I'll refer to it as MLDS, has a distinct clinical phenotype. Children with Down syndrome have a 150-fold increase of developing this type of myeloid leukemia, and at a younger age. As can be seen by this graph here on the right, it really peaks between 1 and 2 years of age and is virtually non-existent beyond 4 years of age. Unlike AML in the non-Down syndrome population, patients with MLDS often have preceding cytopenias and myelodysplastic syndrome, which is pretty unusual in non-Down syndrome children, where their AML comes on acutely de novo. The megakaryoblast phenotype is common, AMKL, which again is a rare subtype of acute myeloid leukemia in the non-Down syndrome population. They very rarely have involvement of the CNS, and chromosomal translocations common in non-Down syndrome AML are vanishingly rare. What's the natural history of MLDS? So within the first few months of life, approximately up to a third of children with Down syndrome will develop a transient abnormal myelopoiesis. And this will present with increased numbers of blasts in the peripheral blood. And so it's not uncommon for pediatric hematologists to get a consult from the NICU where they have a baby that has an elevated white count and the differential shows blasts. And one of the first questions that hematologist will ask is, does the baby have Down syndrome? The majority of kids with Down syndrome, though, have normal hematopoiesis. Of those children that develop TAM, approximately a third of them will go on to develop MDS and myeloid leukemia of Down syndrome, whereas the majority of them develop normal hematopoiesis. What is the cause that underlies MLDS? We know that this is a mutation in the transcription factor GATA1. GATA1 is encoded on the X chromosome, and this is a somatic mutation, so only affecting those blood cells in which it is found. It is not germline. It is clone-specific, and these mutations tend to occur particularly in exon 2 of the GATA1 gene, resulting in a shortened version of GATA1, or GATA1S. In transient abnormal myelopoiesis, the GATA1 mutations are the same. So in children that first develop TAM and then go on to develop MLDS, they will have the same GATA1 mutation in their transient phase as in their leukemia phase. MLDS evolves from a subclone of transient abnormal myelopoiesis. So if we think about fetal hematopoiesis, you have trisomy 21, where you have 3 copies of chromosome 21 in every cell in that child. In a proportion, again, 10 to 30% of these kids with Down syndrome, they will develop a somatic GATA1 mutation that will lead to transient abnormal myelopoiesis. But in the majority of those patients, there's spontaneous resolution without any treatment or intervention required. In a subset, 20 to 30%, that latent TAM clone will acquire other mutations, and those mutations include cohesin complex mutations, epigenetic regulators, JAK, MPL, and KIT kinases, and RAS pathway mutations in various percentages, and with the addition of those mutations, there will be progression to MLDS. Now, as mentioned, MLDS is unique compared to other types of non-Down syndrome myeloid disease and actually have a superior outcome. As can be seen from this graph, and this is old data now from a number of studies, patients with MLDS, so those are kids younger than age 4, and here divided into age 0 to 2 and 2 to 4 years of age, have event-free survivals well over 75% compared to those that are over 4 years of age with Down syndrome, who are much more likely to have non-Down syndrome type AML. That favorable outcome is highlighted here by a study by the BFM group, as well as by the Children's Oncology group, where you see event-free survivals close to 90% and overall survivals of almost 90%. Again, outcomes that really are unheard of and really desirable in non-Down syndrome AML. So why did these patients with MLDS have such a good outcome? At least part of it seems to be the increased sensitivity of the blasts to chemotherapy. As can be seen by this chart here, where we're looking at the LC50s of drugs that we commonly use in AML, comparing MLDS blasts to non-Down syndrome AML, you can see the increased sensitivity, particularly to cytarabine or Ara-C, but also increased sensitivity to anthracyclines like daunorubicin, idarubicin, and increased sensitivity to etoposide. Now, while patients with MLDS respond well to these drugs, they also have increased toxicity, and in particular, increased cardiac toxicity. And as can be seen from this study in the Journal of Clinical Oncology led by Maureen O'Brien, patients with Down syndrome are more likely to have cardiac toxicity, whether they've had underlying congenital heart disease, but even in the context of having no underlying congenital heart disease, they can develop cardiomyopathy from anthracycline chemotherapy. And importantly, that cardiotoxicity is dose dependent. So the higher the doses of anthracyclines, the more likely these patients are to develop cardiac symptomatology. And so because of that increased sensitivity to chemotherapy of MLDS blasts, and because of the cardiotoxicity, patients with MLDS really should be treated differently than patients with non-Down syndrome AML. In the past, these patients were all treated on the same protocols. But a number of years ago, the Children's Oncology group, as well as other collaborative groups, began with ML Down syndrome specific trials to try to retain the high event-free survival, the excellent outcome in these patients with therapy reduction. The first such study of the Children's Oncology group was named A2971, and this used a typical backbone with anthracycline, in this case daunorubicin, Ara-C, and 6-TG, elimination of etoposide and dexamethasone, one course of Capezi-2, so high-dose Ara-C and asparaginase, with 7 intrathecals, and the 5-year outcome data were comparable to CCG2891, which was the predecessor study where Down syndrome children were treated along with non-Down syndrome children on the same protocol. So excellent event-free survival and overall survival in this patient cohort. The subsequent COG study, AAML0431, again used a similar backbone, moved up the Capezi-2 as the second cycle, reduced the anthracycline further from 350 milligram per meter squared to 240 milligram per meter squared, reintroduced etoposide, and reduced the number of intrathecals down to 2, because as mentioned earlier, CNS disease is vanishingly rare in this population. And again, excellent event-free survivals and overall survival. And in fact, right now, this therapy, 0431, is our standard of care in Down syndrome, which has the best event-free survival and overall survivals of any of the studies published. Now, one of the things that we noticed in these treatment regimens is that while we reduced the anthracycline, we continued to give high-dose Ara-C, a drug that's quite important for both non-Down syndrome and Down syndrome-related myeloid disease. And as you can see here in the 0431 study, induction 2, where we moved up the high-dose Ara-C, the Capezi-2, was associated with the highest rates of febrile neutropenia, sterile site bacterial infections, and ICU admissions. So while high-dose Ara-C is effective, it's associated with significant toxicity, and we know that these Down syndrome patients are vulnerable and don't do particularly well with sepsis. So we began thinking, is there a way to further reduce therapy for this population, particularly with regards to the high-dose Ara-C? And evidence for being able to do this successfully came from our Japanese colleagues who reduced their Ara-C substantially, combined this with pirarubicin, a drug not available in North America, but a similar anthracycline to daunorubicin, and etoposide. So there was no high-dose arteribin, no intrathecal chemotherapy, with low anthracycline cumulative dosing, and they were able to achieve an impressive event-free survival and overall survival in this population. So this really gave other cooperative groups the ammunition to think that we maybe could reduce or even eliminate high-dose Ara-C in this population and continue to get the good outcomes. And so this slide summarizes the evolution of trials for MLDS with the introduction of specific Down syndrome AML protocols with a stepwise reduction in treatment intensity, summarizing those from the Children's Oncology Group, which I've already shown you, the transition from A2971 to AAML 0431, and then the decision to try to eliminate high-dose Ara-C for those patients that were MRD or minimal residual disease negative after the first induction cycle, reducing the intrathecals from 2 to 1 on AAML 1531, which I will talk about more in a moment. And then the BFM, the Berlin Frankfurt Munster group in Germany and in Europe, moving from BFM 98, where they eliminated etoposide and maintenance therapy that they previously gave in MLDS 2006, and then to move from MLDS 2006 to MLDS 2018, where they looked at the introduction of CPX 351, which is a liposomal form of daunorubicin in a molar ratio of 5:1 cytarabine and daunorubicin, and lower dose, high dose Ara-C if MRD negative. And that was their MLDS 2018 study, which I'll speak about more in a moment. So this is the study schema for AAML 1531, which I co-led for the Children's Oncology Group along with Hans Hitzler from Sick Kids in Toronto. This was for all patients with Down syndrome who were younger than 4 years of age, who classically have MLDS. In order to enroll on the study, these patients had to have proof of having Down syndrome by karyotype or be mosaic for Trisomy 21. They had to be younger than 4 years of age and have a GATA1 mutation. They all received a common induction, and then at bone marrow at the end of their induction, and this induction was similar to what we saw on the 0431 study with 6TG, Ara-C, daunorubicin, and a single intrathecal. Following the induction, they had a bone marrow and had an MRD risk assessment. And this was really the first study that looked at a risk-based therapy for MLDS, looking at MRD at the end of induction 1 and whether this was predictive, similar to what we've seen for non-Down syndrome types of AML and many types of ALL in both pediatrics and adults. And this was based on the 0431 study, where patients who had MRD done at the end of induction and were found to be MRD negative were found to have a better outcome with the same treatment than those patients that were MRD positive. So this seemed like a logical biomarker to use to assess MRD in these patients and make a decision whether they received so-called standard arm therapy in which case we eliminated high-dose Ara-C, which I've shown you was the source of bacterial infections, sepsis, ICU admissions in this population, or those that were MRD positive that were then treated on arm B and called high-risk patients, where they received intensified chemotherapy, much more like what the high-risk arm of the non-Down syndrome AML study was giving at the time. And even though we know these patients are at risk for toxicities, that these Down syndrome patients are vulnerable, we felt we could justify this in the population that was MRD positive, because we know that these patients can go on to relapse, and those patients that relapse have a very poor outcome. So we needed to intensify therapy up front. And we used a threshold, an MRD threshold of 0.05% by multi-parameter flow cytometry that was done centrally at Hematologics in Seattle to determine those patients that were deemed standard risk, who then went on and had 4 cycles of therapy like the 0431 study, but without high-dose Ara-C, or those patients that were 0.05 or greater who went on to receive intensive therapy with mitoxantrone Ara-C, Capezi, high-dose Ara-C and etoposide in intensification 1, and Capezi, high-dose Ara-C and asparaginase in intensification 2. So what were the results of this study? Well, unfortunately, we found that eliminating the high-dose Ara-C for the standard risk patients resulted in an inferior outcome. And so this study underwent, the Data Safety Monitoring Board evaluated this study at 2 years, halfway through the proceeding of the study and recruitment, and found, as you can see in these graphs, that those patients that were MRD negative on the 0431 study, where they received high-dose Ara-C, had an improved event-free survival compared to those patients that were standard risk who were MRD negative on the 1531 study with a significant p-value. The overall survival wasn't a significant difference, but still the patients who were MRD negative on the 0431 study who received high-dose Ara-C did better. And that resulted in the closure of that study for an amendment and recommendation that those patients continue on treatment as per the 0431 study and receive a course of high-dose Ara-C. Now, what about those patients who are MRD positive on arm B who received intensification of chemotherapy? Again, in this arm, and the study reopened after that amendment for arm A so that we could continue to enroll patients on arm B. And again, on this arm, we found that the intensification of chemotherapy did not improve survival for these patients. So adding intensive treatment did not improve the outcome, but it did increase the frequency of febrile neutropenia and sepsis. And so really this intensification of chemotherapy is not really feasible in this population. So despite the toxicity that was seen on the high-risk arm, the increased risk of sepsis, the main cause of treatment failure in both the standard risk patients and the high-risk patients is relapse. And those patients that relapse after their initial treatment for MLDS really have dismal overall survivals, whether they're standard risk, in this case, these were the patients that were MRD negative, or high risk, these are the patients that received intensive therapy and were MRD positive. And so this reminds us that while MLDS is a highly treatable disease, and as I showed you at the outset of this presentation, has overall much better event-free and overall survivals compared to non-Down syndrome AML, when these patients relapse, their salvage rates are really low. And so our first chance of cure in many ways is really our only chance of cure. So can we try to understand better what's happening with these patients? Clearly, the intensification of treatment did not make a difference. It only provided toxicity without benefit. Can we try to sort out and understand the biology of these patients better? And the first clue to this really came from our Japanese colleagues and this paper from Sato et al. That came out in Blood a couple of years ago. And what they did was whole exome sequencing or targeted sequencing of over 200 MLDS patients. and they looked at event-free survival and overall survival based on specific genetic features. And what they found was that patients that had these genetic features, any of them that were positive for specific mutations, were actually had a much poorer event-free survival and overall survival compared to those that were negative for any of these mutations. So what were these mutations? Those are listed here: CDKN2A, TP53, ZBTB7A, and JAK2. So some of these genes may be familiar to you, like P53, and some may not. And here you can see, though, the prevalence of these is still relatively low in their cohort, but the outcomes for any of these here with 3-year event-free survival Kaplan-Meier curves is much worse, with the worst being particularly for TP53. So at the Children's Oncology Group, we took this information, looked at these 4 biomarkers, and mapped these back onto the patients that we had enrolled on AAML 1531 to see if these high-risk, so-called high-risk molecular features could correlate with outcome. And we found that actually they did correlate with outcome, and it was independent of MRD at the end of induction 1. So whether these patients were MRD positive or MRD negative, their event-free survival and their overall survival was much worse if they had the presence of these molecular high-risk markers. Again, we were only able to look at small numbers of patients in this group, both in the standard risk patients and in the high-risk patients, but it suggests that even in this cohort, those molecular markers are really important in terms of being able to assess risk. The problem is that they are still not that frequent. And so how do we approach future treatment for MLDS? So I want to share with you some of our thoughts about what we're thinking about for future clinical trials in MLDS at the Children's Oncology Group. So first, there's no role for us to include CPX351. I previously mentioned this agent, which includes a liposomal form of daunorubicin in an effective molar ratio with cytarabine. And the idea of introducing this drug was the thought would be it would be less cardiotoxic and more efficacious. However, data from the Children's Oncology Group study AAML 1831, which was in de novo AML in non-Down syndrome patients, demonstrated that there was an inferior outcome to CPX351 compared to standard daunorubicin and cytarabine. And data from the most recent BFM MLDS study that I referenced earlier, where induction therapy of cytarabine and idarubicin was replaced with CPX351, resulted in a 2-year event-free survival that was significantly inferior. And this was just recently published in Blood. So we do need to look at new agents, though, to treat MLDS. And we want to introduce these up front so that we can give all of these patients the best chance of cure the first time round. And the first of these agents is azacitidine. Azacitidine is a pyrimidine nucleoside analog of cytidine. It incorporates and disrupts RNA and protein synthesis. That's a well-known mechanism of azacitidine. But it also incorporates into DNA and covalently binds DNA methyltransferases, targeting them for degradation. And in such a case, it results in DNA hypomethylation, which results in the reactivation of silenced gene expression and cell differentiation. And we do know that in MLDS, there is a hypermethylation of hematopoietic promoters. And so the use of azacitidine has the potential to remove that hypermethylation and result in downstream gene expression and cell differentiation. And importantly, since we're considering applying this to all patients with MLDS, it has a good safety profile. The second agent is Mylotarg, gemtuzumab ozogamicin, which we often abbreviate as GO. This is a humanized Ig4 anti-CD33 monoclonal antibody that's conjugated to the potent anti-tumor antibiotic calciumycin, and really has been around for a very, very long time. In some ways, it's really the first example of immunotherapy where it targets CD33 on the surface of myeloid blasts and introduces calciumycin as its cargo and destroys those cells. Importantly, Mylotarg has been FDA approved for CD3 positive AML in adults, refractory CD3 positive AML in adult and pediatric patients over 2 years of age, and then most recently for newly diagnosed CD33 positive pediatric AML patients greater than a month of age. Importantly, together with our colleagues at Hematologics, we've been able to show that most MLDS blasts express CD33, and we do know from non-Down syndrome AML that Mylotarg needs to be given early in therapy to be most effective, as the NOFO group showed that when it's given later in therapy, it really doesn't have much impact. And so with these considerations in mind, this is a draft of what our schema is that we're proposing for the next MLDS trial, where we will have a common induction that I showed you on 1531 with the addition of azacitidine as a prephase, so-called priming. So we will prime with azacitidine before we give chemotherapy, and we will include GO in the first cycle in induction, because as mentioned, it has to be given early. That will then be followed by a second course of induction with high-dose Aracene asparaginase, Capezi-2, which we showed on AAML0431 was most effective when given early in therapy, followed by 2 more induction cycles of TAD, and then 2 more intensification cycles of etoposide and Aracene. We will give AZA priming before each of those cycles, except for the second high-dose Aracene and asparaginase cycle. And importantly, we will do whole exome and whole genome sequencing of these blasts to look at those high-risk molecular markers and potentially identify additional molecular markers that may be predictive. So for my last couple of minutes, I want to share some practical considerations in MLDS. I often receive emails and texts from colleagues across North America asking me how best to manage their patients with MLDS. So I want to share some pearls of wisdom here. First, making the diagnosis. Remember, MLDS is a different disease than non-Down syndrome AML. The blast percentage in the bone marrow can be lower than the traditional 20% that we're used to thinking about in de novo AML, because many of these patients go through an MDS or myelodysplasia phase first. Actually, making the diagnosis can also be challenging from a technical perspective. Since many of these patients have acute megakaryoblastic leukemia, they can have significant fibrosis in their bone marrow, and that can make actually doing the bone marrow challenging. And so all these patients should have a trephine biopsy. MRD and AML, I've shown you on the 1531 study on its own, really is difficult to use as a predictive tool of which patients should have a reduction in therapy, which is why we recommend treating all patients the same at this point. But if you get an MRD result, it really should be done in a reference lab, and preferably Hematologics in Seattle, because they have developed expertise in being able to interpret the bone marrow in patients with MLDS. A regenerating bone marrow in these patients can be tricky to interpret because they can have non-malignant myeloid precursors that express CD56 that could easily be mistaken for minimal residual disease, which we've been able to show in looking at bone marrows of kids with Down syndrome and ALL is really just a feature of the recovering bone marrow. The starting of treatment in these patients is also different than non-Down syndrome AML. The urgency is less. These patients usually do not present acutely with a high blast count where you need to start therapy right away. And in fact, if these patients present and have an infectious complication, it's really important to first have them recover from that infectious complication before starting chemotherapy that will render them myelo and immunosuppressive. Whether you start treatment when they're in the MDS phase or if they progress further to the AML phase, we've shown now on repeated studies that the outcomes are the same. So our current treatment recommendations are to treat as per AAML0431 with high-dose Aracene asparaginase, Capezi-2 as the second cycle. As mentioned, the outcomes from this study internationally are still the best EFS and OS in MLDS. Our goal is to open AAML 2531 soon. This will be the new COG study. And as mentioned, our hope is to be able to add azacitidine and Mylotarg on the 0431 backbone. In patients that have refractory or relapse disease, there is no standard approach. And as mentioned, this can be a very difficult disease to cure. Recommendations include some sort of anthracycline and Ara-C. So we often suggest ida-flag, so idarubicin, fludarabine with GCSF priming, or mitoxantrone and Ara-C. And if the blasts are CD33 positive, adding Mylotarg. If you're able to get these patients into remission, taking them to consolidation with an allogeneic stem cell transplant, though as Hans has shown and others have shown as well, the outcomes are poor in these patients taking them to transplant. In kids that are particularly vulnerable, consider azacitidine as a single agent or adding azacitidine into therapy, as we're planning to do on the upcoming study. And in kids with Down syndrome that are older than 4 years, as was shown by the NOFO group and others, these patients really have disease that is much more similar to non-Down syndrome AML. Typically, they don't have GATA1 mutations, and they really should be treated as per non-Down syndrome AML. So with that, I'd like to conclude. I'd like to thank all the patients, families, and centers who have participated in all the COG studies I've mentioned, as well as those that participated on studies of our colleagues in the NOFO group, the BFM group, and the Japanese Leukemia Study Group. I want to particularly thank Dr. Hans Hitzler from Sick Kids in Toronto, who is my co-chair of the 1531 study, and all the members of the 5131 study committee. I want to thank the upcoming 2531 study committee, who's been working on the concept that I shared with you, and all the other members of the COG Myeloid Disease Committee. And with that, I'll conclude and look forward to taking any questions.
It's my pleasure to welcome our final speaker of the day, Dr. Brian Niemeyer. Dr. Brian Niemeyer has done all of his training and has received his education at the University of Colorado. He completed his PhD in 2017 in immunology by completing a doctoral thesis on viral infection of immune cells. In his postdoctoral education, he worked with Dr. Kembez Ben-Em, where he focused on tissue engineering using advanced 3D cell culture systems, which includes organ-on-chip technologies. More specifically, he was able to develop a bone marrow on a chip using primary hematopoietic stem cells that supports niches of mature innate immune cells capable of responding to inflammatory stimuli. Currently, he's working as a postdoctoral fellow at the Linda Cernick Institute for Down Syndrome at the University of Colorado, where his research builds upon these model systems of Down syndrome by integrating cutting-edge approaches in gene editing, cellular reprogramming, and tissue engineering. Specifically, he has induced pluripotent stem cells derived from individuals with Down syndrome to recreate tissues in vitro using 2D and 3D culture systems and organoid-based approaches. More specifically to patients with Down syndrome, he currently serves as the scientific project manager for the newly established Include Down Syndrome Biorepository, which is the primary biorepository that supports NIH's Include-funded Down syndrome research. Please join me in welcoming Dr. Niemeyer to speak about immune dysregulation in Down syndrome.
I would like to start by thanking the event organizers for giving me this opportunity to present this work. And so my talk today is going to be looking at immune dysregulation and Down syndrome. And so before we begin, I just want to let everybody know that I have no conflicts of interest to disclose with this work here. So to begin with some background about the basics for Down syndrome, it is caused by the triplication of chromosome 21, which is also known as trisomy 21. This was first identified as the causative agent for Down syndrome back in the 1950s. And what's really unique about Down syndrome is that this is the only requirement for the development of Down syndrome. So a simple 1.5x increase in gene dosage for chromosome 21 is sufficient here. Now, chromosome 21, when it was sequenced, was found to encode approximately 225 genes, many of which regulate the development and the function of the immune system. So one thing that I want to highlight to this particular community is that the life expectancy within Down syndrome has really skyrocketed over the past several decades. So when it was first discovered, the life expectancy here was really only about 30 years of age. But with improvements in healthcare as well as a better understanding of this particular condition, we see that there is a drastic increase in life expectancy up to currently around 60 years of age. But one thing to note with this is that with this improved life expectancy, there is a need for a better understanding of how Down syndrome changes and shifts over the age and over the lifespan of these individuals. Now, one thing that I want to highlight with Down syndrome is that it has a unique spectrum of phenotypes. So any given individual that has Down syndrome, it can present in a very unique fashion to any other given individual. So what's interesting about this is that the same triplication of chromosome 21 here will result in this diverse range of different phenotypes. And many of these are kind of hallmarks of Down syndrome, what we typically associate with them. So we commonly see development of intellectual disabilities, delayed forms of development with language disorders, psychiatric conditions such as anxiety and depression. These are all very common within Down syndrome, but we also see a lot of co-occurring conditions that are not typically thought of. So hematological issues like immune dysfunction, which we'll talk about more in depth throughout this presentation here, but then also increases in sleep apnea, respiratory tract infections, and a high incidence of autoimmunity here. And what I want to highlight, particularly with these asterisk co-occurring conditions here, is that many of them have strong immune components to them. And so one of the things that we'll talk about is how immune dysregulation in the context of Down syndrome can contribute to some of these co-occurring conditions here. So specifically with looking at susceptibility to infection, what we see is that individuals with Down syndrome have higher incidences of pneumonia as well as otitis media, and then also higher incidences of other underlying conditions that have infectious components to them, but are not necessarily caused directly by an infection. So a perfect example of this would be hidradenitis suppurativa, which is an inflammatory skin condition where a person develops these boils that are heavily inflamed, and then there is an underlying microbiota that can contribute to the progression of these as well as hinder the resolution of them, although they don't directly cause hidradenitis suppurativa. But what I want to highlight with respect to Down syndrome here is that while these are more prevalent in this population, there are both immunological and non-immunological factors that can drive this. So some immunological factors, for example, would be suboptimal antibody responses, poor chemotaxis of immune cells here. And then in addition to this, the non-immune factors would be alterations in anatomy. So for example, changes in airway structure can lead to increased respiratory infections by the narrowing of an airway, or alterations in the ear architecture can also drive increased incidences of otitis media here. To dive into this information a little bit more in depth, what we can do is take a look at recent studies that looked at the increased incidences of pneumonia caused by different infectious agents in the Down syndrome population. And what we see here is that over the course of the lifespan, there is an increase in the incidence of all-cause pneumonia here. And this is true for any individual regardless of their age, including young individuals with Down syndrome all the way to those who are older, being over 50. And then this increase in the incidence of pneumonia occurs regardless of many of the different causes. So you can have an increased incidence with pneumococcal pneumonia, also with IPD, influenza-associated pneumonia, as well as just influenza infection itself. But this higher rate of infection is not necessarily the only problem that these individuals experience when it comes to this. What we also see is that after developing pneumonia, there's this increased incidence of mortality within this population. So in the same study that was looking at the incidence of pneumonia in the previous slide, the researchers here wanted to understand a little bit better the risk for mortality within the Down syndrome community. And what they found was that if they tracked the individuals who developed pneumonia over the course of a year, there was a significant increase in mortality within the Down syndrome population compared to individuals without Down syndrome. So what they found was that the incidence of pneumonia was roughly 5 to 6-fold higher in individuals with Down syndrome. And as I mentioned on the previous slide, this is regardless of age. And that Down syndrome, as mentioned, is associated with a higher risk of mortality in pneumonia instances that they measured. But this is also true for other types of respiratory infections. So in a similar study that I'm not showing here, it was found that individuals with Down syndrome were found to be 5 times more likely to be hospitalized due to COVID. And then those individuals who were hospitalized with COVID were 10 times more likely to die from it compared to individuals without Down syndrome. Apart from increased incidences of infection, we do know that individuals with Down syndrome have higher rates of autoimmunity. So just to give you kind of a quick reminder about autoimmunity, typically when your immune system develops, there is kind of a tolerizing process where your immune cells are trained not to recognize and respond to your own cells in your own body. This self-tolerance will allow your cells to survive and essentially not activate the immune system, but still facilitate clearance of bacteria and pathogens here. Now, in instances of autoimmunity, this actual tolerance kind of gets broken down where your immune cells no longer understand that your own cells are not a foreign invader, and instead they start to attack and develop an immune response where you'll have increased rates of inflammation and worse outcomes with that. So what I want to highlight with specificity to the Down syndrome community is that adults with Down syndrome, over 75% of them have at least one autoimmune condition. And so what we've highlighted over here is essentially some of the common ones that we see, many of which are autoimmune skin conditions. So alopecia areata, atopic dermatitis, hidradenitis suppurativa, psoriasis, for example. Those are all elevated in individuals with Down syndrome. But it's not only autoimmune skin conditions that we see. We also see increased incidences of autoimmune thyroid disease, elevation of celiac disease, and then things like type 1 diabetes as well. So these are all really common within individuals with Down syndrome. So I just wanted to highlight some of these co-occurring conditions a little bit more while we kind of go into what the remainder of this presentation will be. So the roadmap for the remainder of the talk is really going to be highlighting what is altered in terms of immune cell composition and function within Down syndrome, and then how those altered immune cells and functions impact co-occurring conditions within this population. And then interferon signaling in Down syndrome and how elevated interferon signaling contributes to this dysregulated immune cell composition. And then finally, we're going to talk about some therapeutic interventions that are focused on mediating this hyperactive interferon signaling. So to start with alterations in terms of immune cell composition and function, I just want to give kind of a brief overview of the immune system. I'm sure many people here are well familiar with this, but for anybody who needs a quick refresher, in adults, your immune system typically develops within the bone marrow, where you'll have hematopoietic stem cells that give rise to, broadly speaking, 2 branches of your immune system. There's the innate branch of your immune system, which is predominantly comprised of myeloid cells, including eosinophils, basophils, monocytes, and neutrophils. And then on the other branch, you have the lymphoid tissues, which include T cells, B cells, plasma cells, and then you have some innate-like lymphoid cells like NK cells here. So if we were to try and dig a little bit deeper and understand how the immune cells look in an individual with Down syndrome, the first thing that we realize is that there is global dysregulation within Down syndrome. So what I mean by this is if we take peripheral blood and we characterize the frequency of these different immune cell subsets, what we see is that in a typical individual, we'll find around 7 main lineages, although these could be subdivided to be more unique or specialized. But broadly speaking, we'll have neutrophils being the main component of your blood here, followed by T cells, monocytes, NK cells, B cells. All of those are found present within your peripheral blood. Now, if you compare typical individuals to individuals who have Down syndrome, what you start to see is shifts in these populations where essentially there's an elevation in the frequency of basophils and neutrophils, and then you have a concurrent decrease in the frequency of B cells and eosinophils and T cells here. But this is really just kind of a broad overview of major lineages here. So what I want to highlight is that within each of these different major lineages, if you look at subpopulations within them, you can see that every branch of the immune system is heavily dysregulated here. So instances of naive T cells, memory T cells, for example, we see massive remodeling within populations of those in individuals with Down syndrome. And then you see that there's not really a trend of increasing or decreasing in terms of cell types. You have this kind of fluctuation where certain subpopulations of cells are depleted in T21, which is indicated in blue here, and then other cell populations are increased in T21. And the big take home I want you to get from this is not necessarily what every cell type is doing, but it's really just the global aspect of this, and that every branch of your immune system is impacted by trisomy 21. That being said, I do want to highlight some specific instances and specific cell types that are dysregulated in Down syndrome and how those contribute to some of the co-occurring conditions we described earlier. The first cell type that I'd like to talk about are B cells, and that's mostly because B cell lymphopenia, so a loss of B cells, is a major hallmark of Down syndrome. B cells happen to be one of the cell types in your immune compartment that is most impacted by trisomy 21. So what you can see here is that if you look at individuals who have Down syndrome, and you measure the frequency of B cells of the total live cells within their circulating blood, you see that there's this massive depletion here. Now, this is not uncommon for individuals to have a depletion of B cells over time. As we age naturally, we start to lose B cells. But what's interesting is that if we look at the trajectory of B cell loss over time in individuals with Down syndrome, you can see that this loss of B cells is not really associated with a particular age bracket. Instead, this seems to be very consistent throughout the life of the individual. So this is highlighted on these plots here, where in green, we're looking at the individuals with trisomy 21, and then in gray, we're looking at the typical population, and then we're highlighting a few sliding scale windows of different age brackets. So if we look at around age 10 or so, you can see that there's depleted B cells present here. Shift this scale up to age 20, you can see that that depletion is still present, and then it carries out through age 30 all the way down to age 60. So this B cell lymphopenia persists throughout the life of the individual with Down syndrome. But that doesn't really tell the whole story either, because we know that there are a lot of different subsets of B cells, each which have their own specialized function. So similar to what we did in the previous slide, if you try and look at the different subsets of B cells to see how they're impacted within the B cell population in individuals with Down syndrome, you can see that there's massive remodeling within this compartment as well. So what I'm showing you here is that individuals with Down syndrome have a higher frequency of plasmablasts, as well as these age-associated B cells, also called ABCs, that are present. So within the B cell compartment, you're seeing that there's this shift in the landscape here. So you get this kind of 1-2 hit with B cell populations in Down syndrome, where first there's a depletion of total B cells. And then even within the B cells that you have left, there's a change in terms of the type of B cell that you have present. And I want to just bring your attention to the age-associated B cells, because as the name suggests, this is something that is typically seen as we start to age. Any typical individual without Down syndrome will start to accumulate age-associated B cells over time. And what is interesting about these cell types is that they seem to be less efficient at doing their job. They don't really behave the way that a typical B cell should behave. Instead, they seem to promote more inflammation, and they also seem to be associated with autoimmunity and the production of autoreactive antibodies. In addition to increases in these frequencies of cells, I want to highlight that this comes at the expense of a really important cell type for immune responses, and that would be switched memory B cells. So anytime that you need to create kind of a memory response, either due to a vaccine or when you get exposed to a pathogen, one of the things that you really want is to have a healthy population of memory B cells that are able to rapidly recognize that they've seen this pathogen before, and that they can then start producing, more antibody cells, antibody-producing cells such as plasmablasts, and create kind of a rapid recall response here. So in individuals with Down syndrome, we see the shift where we have elevations in plasmablasts and B cells, age-associated B cells specifically, but we see a diminished compartment within switched memory B cells. But the changes in terms of the types of cells that we have here doesn't necessarily give us insight into whether this causes problems for these individuals or not. So although they might have elevated plasmablasts, for example, within their B cell compartment, that doesn't necessarily mean that they have B cell dysfunction here. The plasmablasts may be functioning the way that we would hope that they would, and they could potentially control infection. However, since we know that individuals with Down syndrome are more susceptible to infection and have worse outcomes post-exposure to pathogens, several groups have looked into whether or not antibody production from some of these B cell subsets is altered within Down syndrome. And so one group out of the Netherlands created a study called the PRIDE study, where they essentially wanted to understand whether individuals with Down syndrome were able to create a really robust antibody response to SARS-CoV-2 vaccines. So for this particular study, what they did was they split individuals with and without Down syndrome into sort of two arms here. One arm which received an RNA-based virus vaccine system, and another which received a vector-based vaccine system. And then they measured antibody titers and the capacity for the antibodies that were produced to neutralize the virus post different stages of vaccine boosters. And so when they performed this study, what they found was that the individuals with Down syndrome, which are shown in blue here, by the time they gave their last booster, there was a significant decrease in the amount of antibody that was produced against the S protein for the virus here. And this was true for both the RNA-based and the vector-based vaccine. So regardless of which vaccine type they got, by the time the last booster hit, there was this impaired ability to produce antibodies in response to vaccination. But the failure to produce antibodies is not the only thing that came out of this study. When looking at the age of the participant post-vaccine, what they found was that there was an increased decline in antibody production in the Down syndrome population with age compared to typical individuals. So you can see this more drastic slope of the line here in terms of antibody production in older individuals with Down syndrome compared to typical individuals. And this was really severe for only one of the types of vaccines that was provided to these individuals, but it was quite striking. To take this a step further, as I mentioned a few slides ago, they also wanted to measure whether these antibodies were able to neutralize the virus. So in this assay, what they found was that regardless of the vaccine type that was given, there was an impaired ability for the individuals with Down syndrome to produce neutralizing antibodies. So essentially, this kind of creates a landscape where now you have an individual who has Down syndrome. They have fewer B cells, but within their B cell compartment, they have more plasmablasts. But those plasmablasts are not providing the same amount of protection and antibody response that a typical individual would. So they have less antibody that's being produced, and the antibody that is being produced is less efficient at neutralizing its target the way that it should. Now, in addition to some components of this that might contribute to increased susceptibility to infection, one thing that we want to consider when talking about B cells is also their contribution to autoimmunity. So when we think about autoimmunity, one of the things that we think about are production of autoantibodies. Since we see an increase in terms of age-associated B cells, there has been a big push in the community to try and understand whether or not there's a predisposition of B cells to become more autoreactive. And so with respect to this, there was a recently published study from 2023, which found similar trends to what I showed earlier, where there was an increase in what would be considered these age-associated B cells that are more prone to become autoreactive, for example. And within those B cell populations, they found that when they sequenced the B cell receptor, there was a specific V segment usage that is associated more commonly with autoimmunity that seemed to be elevated in individuals with Down syndrome in pink compared to typical individuals that were in gray here. And then what was also striking about this was when they took these B cells and stimulated them, they saw that there was an elevation in production of this 9G4 antibody, which is associated with autoimmunity, particularly in conditions like SLE. If they took this a step further and then characterized the amount of antibody or the type of antibody that was produced in these individuals, what they saw was that there was actually an enrichment of autoantibodies that were produced in people with Down syndrome. So in this set of experiments, what we're looking at here is a comparison of individuals with Down syndrome to individuals that have a different type of autoimmunity, such as IPEX or APS1, compared to healthy controls in gray here. And what they found was that the antibodies that were produced from this tended to track away from healthy controls when looking at the Down syndrome population. And more importantly than that, the number of autoantigens that these antibodies recognized were elevated in the Down syndrome group compared to healthy typical controls as well. And so I think this is actually best highlighted by this heat map here, where they're looking at different abundances of autoantigens or autoantigen recognizing antibodies in individuals with Down syndrome in the center here, as well as these different unrelated autoimmune conditions compared to healthy controls. And you can see that there's just this massive enrichment of a lot of autoantigens in the Down syndrome group that actually mimics quite well what we see in other instances of autoimmunity here. And then what I'm not showing is that this publication linked this pretty closely to elevated rates of IL-6 production and hyperactivated CD4 T cells. It seemed to be that these might be contributing factors to the expansion of some of these autoreactive B cells and production of autoantibodies here. And so with that, we can segue into T cell remodeling here, because B cells are really not the only component. Anytime that we're dealing with B cell reactions, we do also want to consider their counterpart, which would be T cells. So we can do kind of a similar exercise where we characterize different subsets of T cells and see how they are dysregulated in Down syndrome. And what groups have recently found is that we see massive remodeling within the T cell compartment, similar to what we observe within the B cell compartment here. So individuals with Down syndrome have elevated frequencies of CD8 T cells, which are going to be your cytotoxic T cells, and then a diminish of CD4 T cells. And then within the CD4 T cell population, also what you see is an enrichment of T regulatory cells, which are typically more immunosuppressive, and they are thought to be really important for controlling autoimmunity and autoreactive cells. And then what's interesting too is if you look in the bulk CD8 T cells and bulk CD4 T cells, you see that there's shifts in the different subsets that are present here. So we see a big depletion of naive T cells, both for CD8 and CD4 T cells, with a concurrent increase in different effector memory populations and central memory populations as well. So ultimately, we're seeing increases in cytotoxic T cells and Tregs at the expense of different memory T cell populations. But if we take a look more at the function of these cell types, similar to what we looked at with the B cells, what you can see is that functionally, these cells are very unique in Down syndrome as well. They don't really behave the way that they do in typical individuals. So people with Down syndrome, it seems like their CD8 T cells are more hyperactive. So they're producing more rates of inflammatory cytokines such as TNF alpha, as well as elevated rates of interferon gamma, IL-8, and things of that nature. And then further, if you characterize the amount of CD8 T cells that are expressing at least one or more of these different inflammatory markers here, you can see that there is a shift in the frequency of cells that are expressing them. So what I mean by that is in the typical population, more than half of your CD8 T cells are actually not expressing any of these markers here. Instead, you will typically have some cells that express 1, 2, 3, or 4 of these markers, and you can identify exactly which of these markers are being expressed by the color on the pie chart here along this outer range here. But what I really want to highlight with this is that in trisomy 21, you see that there is this reduction in the frequency of CD8 T cells that aren't expressing any of these. And instead, you have this massive increase in the frequency of CD8 T cells that are actually expressing all 4 of those, showing that they're really hyperactivated and producing a lot of pro-inflammatory cytokines here. Further, we can take a look at the Treg populations because these were actually a population that were elevated in individuals with Down syndrome, and we can see how they function here. So what we're looking at is data that was published doing a T cell suppression assay, where essentially what you'll mix is T regulatory cells with a target cell, a non-Treg cell. In this instance, it would be CD8 T cells here. And then you can look at the ability of this Treg cell to suppress the function of the CD8 T cell. And what they found was that if you have target CD8 T cells that come from individuals with Down syndrome, regardless of whether the Treg cell is from an individual with T21 or D21, the CD8 T cell cannot be suppressed efficiently. Similarly, if you take Tregs from either somebody who has or does not have Down syndrome and put that on a CD8 T cell that comes from somebody without Down syndrome, it is able to suppress the CD8 T cell. So what this suggests to us is that although you have elevated instances of T regulatory cells in Down syndrome, the target cells that they should be suppressing are refractory to that repression. So they're still activated, and it doesn't look like the Tregs are able to actually shut those off. Then to talk about a new population of cells, since we've covered some of the lymphocytes in depth, I just want to bring your attention to the monocyte population here. So if we look at the innate immune cells, particularly monocytes here, these come in 3 different flavors. They can be classical monocytes, which are typically the majority of monocytes that you see circulating in the periphery, as well as inflammatory monocytes, also known as intermediate monocytes. These are typically associated with inflammation and more severe outcomes with infection. And then you also have non-classical monocytes, which are typically patrolling monocytes. They can have elevated instances of antigen presentation, for example. And one thing that's interesting is that in Down syndrome, you don't necessarily see a shift in the total number of monocytes between individuals with and without Down syndrome. But similar to B and T cell populations, what you do see here is a shift in terms of the distribution of the types of monocytes that you have, where individuals with Down syndrome have an elevation of both intermediate monocytes and non-classical monocytes at the expense of the classical monocytes. And so, as I mentioned before, this can be a little bit concerning because intermediate monocytes, for example, are typically associated with pathogenic outcomes when it comes to things like respiratory infection. So there have been quite a few studies that suggest that worse outcomes with influenza infection, for example, can be mediated in part by these intermediate monocytes here. And so what we're looking at on the right is just an example of the shift that we'll see where these intermediate monocytes that are CD14 and CD16 positive are really expanded within individuals that have trisomy 21. But as before, the number of monocytes isn't necessarily the whole story here. Instead, we can also take a look at the function of these monocytes to see how they behave in individuals with and without Down syndrome. And what previous research has shown is that individuals with Down syndrome, if you take their monocytes and look at their capacity to clear out bacteria through phagocytosis, they are impaired in their ability to actually take up bacterial particles and clear that out. Similarly, this was an instance of monocytes with individuals that had periodontal disease. If you look at individuals that don't have any other conditions apart from trisomy 21, what you can see is that this phenotype persists, where uptake of Staphylococcus aureus, for example, is severely impaired in individuals who have Down syndrome, that's indicated in red there, compared to typical individuals that do not have Down syndrome. And then in addition to the ability to phagocytose particles or bacteria, what we see is that individuals with Down syndrome had a decreased ability to undergo chemotaxis. So they migrate less efficiently to sites of infection here. So in addition to monocytes, there are groups who have looked at neutrophil function and frequencies within individuals with Down syndrome. And I mentioned it before, but I'll remind you that neutrophils are actually one of the elevated cell types within Down syndrome. So these individuals have about a 4-fold increase in neutrophils. Similarly to monocytes, if you look at their capacity to perform their functions, such as oxidative burst, it does look like it's dysregulated in Down syndrome. So individuals who have Down syndrome, showed in the center bar here, have elevated rates of oxidative burst compared to healthy controls. And then there is also an impairment in chemotaxis and an increase to responsiveness to other stimuli as well. So just some interim conclusions about the global immune dysregulation that we see here is that Down syndrome contributes to co-occurring conditions in a few different ways. So in terms of susceptibility to infection here, we see that B-cell lymphopenia, dysregulated B-cell and antibody maturation, as well as impaired neutralizing antibody production can all contribute to poor memory response, as well as impaired control of infection. Additionally, loss of things like CD4 T cell populations likely limits the adaptive response to infection because these are really critical cell types to help promote things like B cell proliferation and germinal center reactions, which are required for production of plasmablasts and things like that. And then also we see impaired phagocytosis within monocyte and neutrophil populations, and then impaired chemotaxis within myeloid cells, being the monocytes and neutrophils as well. Then as far as autoimmunity goes, what we see is that there's an increase in autoreactive B cell populations. And in addition to these autoreactive B cell populations, there's a concordant increase in autoantibody production here. We also see elevated cytokine production in hyperactive T cells. And these elevated cytokines typically lead to increased rates of inflammation and are also associated with autoimmunity. And then further, although we have elevated levels of Treg cells in individuals with Down syndrome, the Treg cells don't seem to be able to perform their basic function of suppressing other cell types. But it's not really the Treg's fault. It really seems like it's more the target cell type in individuals with Down syndrome. These hyperactivated cells just seem to be resistant to suppression by the Tregs. And then autoinflammation by myeloid and lymphoid cells is also seen, but it's unclear exactly which of these cell types are driving these. And we definitely need more research into this area to understand this aspect a little bit more. So with that being said, I want to transition and go into interferon signaling a little bit more and describe how interferon signaling might mediate some of the alterations that we just discussed in terms of the immune cell compartment. So as a quick refresher, interferons were initially discovered by their capacity to essentially block or interfere with virus replication and infection. So typically when you have a virus that kind of comes into the body and starts to infect the cell, that cell starts cranking out different interferons. These different interferons will go and interact with different surrounding cells and enter circulation, and they can do a slew of different activities. So they will shut down neighboring cells so that they become less permissive to infection. They will also signal to other infected cells that they need to die, but then they also will recruit immune cells and then alter immune cell function. So they can activate or repress different immune cell functions and capabilities depending on the need and sort of what the milieu looks like there. One thing that I want to highlight here is that with interferons, we have three different types of interferons, broadly speaking. Type 1 interferons, which are characterized by interferon alpha beta. And then we also have type 2 interferons, which would be interferon gamma. And then a third type, type 3 interferons, which are interferon lambda. And then each of these signal through different JAK-STAT pathways that ultimately leads to induction of interferon-stimulated genes, otherwise known as ISGs. And then what I want to really highlight here, and the whole reason why we're talking about this in the context of Down syndrome, is because of the interferon receptors that we have here. You encode 6 different interferon receptor subunits, 2 that are for type 1 interferon receptors, 2 that are for type 2 interferon receptors, and then 2 that are for type 3 interferon receptors. Of these 6 different interferon receptor subunits, 4 of them are actually encoded on chromosome 21. So by default, individuals with Down syndrome have an extra copy of several of these interferon receptor subunits. So if we look at interferon signaling within individuals with that context in mind, what we can see is that trisomy 21 actually results in hyperactive interferon signaling here. So within all 3 types of interferon receptors, we see elevation in expression of those interferon receptors. So that third copy of chromosome 21 does actually correspond with increased expression of interferon receptors on the surface of the cells. The cell types that we're looking at from this publication back in 2016 were actually fibroblasts from individuals with and without Down syndrome. And when we look at these fibroblasts and stimulate them with either type 1 or type 2 interferons, you can see 2 things. First, even without stimulation here, you have elevated rates of basal interferon signaling within individuals that have Down syndrome here. So increased expression of this alone is enough for just basal elevation of signaling. And then when you stimulate it with the interferon ligands, what you can see is that there's this hyperreactive response. So you see a massive induction of ISGs that are both expressed on chromosome 21 and ISGs that are not expressed on chromosome 21 in individuals with Down syndrome. So both baseline and response to interferon stimulation are elevated when it comes to interferon signaling here. And then what you can see are kind of a suite of different interferon stimulated genes, all of which are upregulated in fibroblasts from individuals who have trisomy 21. But fibroblasts are, of course, not necessarily the only cell type that might utilize this system. So I mentioned a couple slides ago that interferons were also responsible for modulating immune responses, particularly to infection, but in other instances as well. And so if you take a look at interferon receptor expression within the immune compartment specifically, not just on fibroblasts, what you see is that the elevated expression of interferon receptors is actually pervasive throughout the entire immune compartment. So looking at interferon alpha 1 receptor expression, for example, across 100 different immune cell types, you see that in the majority of these immune cell types, there is that elevated expression on them in individuals with Down syndrome, indicated by green here. And then similarly, you can see that expression of the RNA level of the interferon alpha 1, AR2, the interferon gamma R2, and the IL-10RB, which are the 4 sets that are encoded on chromosome 21. Those are all elevated at the RNA level. And then within some specific subsets of B cells, you can see the elevation pretty clearly by flow cytometry. So indicated in green here would be individuals with trisomy 21, where for each of these distinct immune cell types, you can see a clear shift in expression of some of the interferon receptors present there. And then in sort of natural progression with this, the increased expression of the interferon receptor and that kind of increased tonic signaling that we saw in the fibroblasts, if you take a look at the transcriptome of individuals who have Down syndrome, you can see that it's really dominated by activation of interferon signaling pathways. So looking at something called a gene set enrichment analysis, where you essentially take the whole transcriptome that you can recover from the blood of an individual with or without Down syndrome, and then measure how many sets of genes are activated within a pathway that would respond to interferon signaling, for example, you see that's highly elevated in individuals with Down syndrome, both for type 2 interferons, which would be the interferon gamma response, as well as the type 1 interferon, which would be interferon alpha response here. And this is kind of consistent with other things that we would expect to see with elevated interferon signaling, including heightened inflammatory responses, alterations in TNF alpha signaling, as well as IL-6, JAK-STAT3 signaling. All of these things would be associated with somebody that we would expect to see have heightened interferon signaling present there. And then what becomes really interesting on the left here, we're really only looking at individuals with Down syndrome compared to individuals without Down syndrome. So this shows the elevation specific to individuals with Down syndrome. But if you compare individuals with Down syndrome to typical individuals without Down syndrome who are experiencing a severe infection, in this case, COVID, it looks like their transcriptome actually is pretty similar. So individuals with Down syndrome almost look like they're actively fighting a severe infection when there is no virus present in their body that can be detected. So this is kind of highlighting this hyper-responsive interferon nature that you would expect to see with an active infection here. But beyond just this elevated interferon signaling, what we can say is that this hyperactive interferon response does contribute directly to shape the immune landscape that we're seeing. So what we're looking at on the left here is essentially changes in the immune cell compartment and how that correlates to changes in different interferon scores. So as an individual with Down syndrome has elevated interferon signaling, we can calculate that interferon score and determine exactly what degree of elevated interferon signaling is happening within that individual. And so when we correlate increased rates of interferon signaling within these individuals, what we see is that there is a really strong association between the immune remodeling. So when I was discussing earlier the dysregulated immune cell compartment, we mentioned that there was an increase in some of these CD8 T cell populations, and more specifically CD8 effector memory cells or non-classical monocytes, for example. Those elevations really do correspond very well to increases in interferon signaling. And similarly, alterations in the naive CD4 T cells correspond with this signaling as well. And so you can see that indicated on the left here, as well as the populations on the right. This is just another representation for changes in interferon score and increases in CD8 T effector cell memory populations. And then similarly, we see a decrease in terms of the naive CD8 T cells present. And then one thing that I want to bring your attention to is that there are distinct sets of interferon-stimulated genes that do seem to correspond to this remodeling as well. So an example of this would be CCL5 and IL-10RA. So these are interferon-stimulated genes whose expression strongly associates with CD8 T effector memories, but not classical monocytes. So as you increase in expression of the ISG CCL5, you get a very clear association with increased CD8 T effector memory responses. And then similarly, within the non-classical monocyte population, there is not this association present there. And then you can see similar trends happen with depletion of naive T cells, both CD8 and CD4, where this strongly correlates with overexpression of a distinct subset of ISGs. So in this case, PSMB8 and then PSMB10, overexpression of those corresponds to the decrease in the CD8 naive and CD4 naive T cell populations, which is indicated by these boxes here. And then within your memory B cell compartment, so B cells that should be CD27 positive, for example, you see that depletion of these typically is associated with increases in IL-10RA and CCL5 expression as well. So what this is highlighting is that you have immune dysregulation and you have hyperactive interferon signaling, and these two things are actually likely linked together. So some of the interim conclusions that we want to draw from the hyperactive interferon signaling here is that individuals with Down syndrome show, first of all, hyperactive interferon signaling. This is most likely a direct consequence of having the extra copy of chromosome 21, which encodes 4 out of 6 of those receptor subunits. That elevation in terms of interferon signaling is pervasive throughout the immune compartment. So many of the different cell subsets express some, if not all, of the interferon receptors. And then transcriptomic and interferon signatures show that on a molecular level, individuals with Down syndrome resemble people without Down syndrome who are actively fighting a severe viral infection, such as the case with COVID. And then elevations in interferon signaling contributes to reshaping of the immune landscape within Down syndrome. So we know that as an individual has increased signaling within interferon pathways, that is associated with increased dysregulation within the different immune cell subsets that they have, and that specific ISGs are really associated with those distinct alterations within those cell populations. So the last thing that I would like to transition into would be looking at interferon-focused therapeutic interventions and how this might impact some of the alterations that we've seen before and might improve some of the co-occurring conditions that happen within Down syndrome. So Using clinical interventions that modulate interferon responses is nothing new. This is something that's been employed a lot for different autoimmune skin conditions like psoriatic arthritis, for example, atopic dermatitis, as well as some other conditions like COVID-19. Typically, the drugs that are currently employed for these types of conditions target the JAK proteins, which are involved in the JAK-STAT signaling that are just downstream of the interferon receptors. And with respect to Down syndrome, one of the questions that we wanted to ask, since we know that there are elevated instances of a lot of these autoimmune skin conditions in Down syndrome, and a lot of these have been treated in individuals without Down syndrome using something called tofacitinib, which targets JAK1 and 3, for example. We wanted to see whether or not modulating JAK1/3 signaling with tofacitinib can improve health outcomes for these individuals. And so with respect to that, I'll highlight what the clinical intervention is and the endpoints of the study. So what we're looking at here is a clinical trial that is a phase 2 open label trial. It was open to all participants who are aged 12 to 50 that have Down syndrome and also have an autoimmune skin condition. These individuals received tofacitinib, and they received this over the course of 20 weeks. And although I'm not showing it here, there is actually an extension arm that goes out to 40 weeks as well. And the primary endpoints for this clinical trial was to understand whether the autoimmune-mediated skin conditions that these individuals had was improved upon inhibition of the JAK-STAT signaling with tofacitinib. Also, we wanted to know whether or not a reduction of interferon signaling improved cognitive testing. And then of course, we wanted to understand the safety of using a JAK inhibitor in individuals with Down syndrome, since this had not been tested before, and then look at differences in terms of circulating immune cells, levels of inflammation and inflammatory cytokines. And then, of course, we can also look at autoantibody production as well. So with that in mind, what I want to first highlight with this particular trial was that it was determined to be safe in individuals with Down syndrome. So there were really not many adverse effects that were observed within this. I will highlight one. There was one participant that did have a very severe adverse effect, which was a thromboembolism, but it was discovered that she had a thromboembolism while also taking oral contraceptive pills, which have been known to increase the risk of thromboembolisms. So I should mention that drugs, particularly tofacitinib, there has been an association with an increased risk for thromboembolism with that. So we think that maybe that, in addition to the oral contraceptive, might have led to that incidence with that person. But apart from that, it was well tolerated within all the participants who received the drug. So the good news is you can provide a JAK inhibitor, in this case tofacitinib, to an individual with Down syndrome, and you don't have to worry about adverse outcomes for these individuals. I think one of the big things that we were concerned about going forward with this was that if they were immune suppressed in many ways, like having an increased susceptibility to infection and also an impaired adaptive immune response, if you throw in a JAK inhibitor that's going to suppress interferon signaling, do you see increased incidences of infection, for example? That was not something that we actually observed, so this is safe for this population. And then importantly, in addition to the safety profiles, it does look like JAK inhibition did improve biomarkers of inflammation. So what you can see here on the left are the interferon scores for individuals at time 0, which had not received any treatment yet, so baseline. And then in addition to this, at weeks 2, 8, 16, and 40, we saw that there was a decrease in the interferon score. So this tracks nicely with what we would expect. So tofacitinib, which is the JAK inhibitor, is suppressing interferon signaling. But more importantly than that, if you look at the transcriptome for these individuals, you can see that we have a correction for a lot of the things that are elevated in individuals with Down syndrome. So this sort of set of graphs on the left here is really just to remind you of what this looks like when we compare individuals with Down syndrome to individuals without Down syndrome, where we see this really high elevation of interferon responses, high levels of inflammation, oxidative phosphorylation, for example. As soon as we give these participants tofacitinib, and then we compare treatment to the untreated individual with trisomy 21, you can see that these start to revert back. So putting an individual with Down syndrome on tofacitinib reduces interferon gamma responses, reduces interferon alpha responses, lowers inflammation and oxidative phosphorylation, and also reduces things like TNF alpha signaling. And again, this is really all at the transcriptomic level, so it doesn't necessarily tell the whole story, but it does give us an insight into what genes are being turned on and what pathways are being activated, and whether or not tofacitinib can blunt those pathways. And so far, it looks like it's able to. But if we take this a step further and actually measure protein levels, what you can see if we measure IL-6, TNF alpha, or IPN10, each of these are elevated in individuals with Down syndrome compared to typical individuals. When we put these individuals on tofacitinib at 2 weeks, 8 weeks, and 16 weeks, you can start to see the levels of these acute phase proteins start to diminish. So we see lower rates of IL-6, lower rates of TNF alpha, and then lower rates of IP10. So not only do we see improvement on the transcript level, we also see protein levels actually start to reduce as well. But again, what kind of matches with the safety data that we see when we put individuals with Down syndrome on tofacitinib, it's not like we are completely removing their ability to express these markers. We're just really bringing them back closer to what we would expect to see within the typical population, which is great. This means that they actually should be able to still mount an inflammatory response if they need to. And then if we take this further and look at incidences of autoantibody production, what we can see is that at least preliminary data suggests that treatment with tofacitinib reduced the load of autoantibodies. And so we're looking at anti-TPO here and then an anti-TG antibody here. And so for the participants that we have data from on this, at baseline in red, we see that these rates go down by 8 weeks, and then we see that these autoantibody loads also decrease further out to 16 weeks as well. And so although this is really only kind of preliminary data and it's only shown for 2 autoantibodies, what we want to do is kind of expand this and understand how this impacts more autoantibody production on a global scale. But of course, the purpose for this trial was to see if blunting interferon responses could improve immune-mediated skin conditions. So one of the endpoints here was to actually look at some of these diverse immune skin conditions that we see and whether or not putting the participant with these skin conditions on tofacitinib improved that. And so what you can see here is that we have improvements seen for alopecia areata. This is measured by SALT scores, as well as eczema, which is measured by the EASI score. And then there's also changes in terms of the IGA scores and the Dermatological Life Quality Index, otherwise known as the DLQI. But what I really find is the most striking about this are the images that we have down here, where we have representative participants here who had either alopecia areata or atopic dermatitis. And what you can see is that at baseline, this individual who had alopecia areata really had very little hair growth. But after 16 weeks of treatment with tofacitinib, this participant essentially has a full head of hair at this point. So there was a massive rebound in terms of hair growth, which was fantastic, really just in terms of a quality of life. I mean, it gave this particular participant a lot of confidence, and he was particularly happy to be able to comb his hair. And then in terms of atopic dermatitis, what we can see is that, again, at baseline, there are these kind of increased lesions here with inflammation present on the skin that you can see, these large patches that are present after 16 weeks of treatment. Those patches were essentially gone, and we couldn't really identify them anymore. So in addition to being safe and well tolerated for the individuals with Down syndrome, this is a very effective treatment at reducing inflammation, suppressing interferon signaling. It looks like it is promising at potentially reducing autoantibody loads, at least for certain autoantibodies that we consistently see elevated in individuals with Down syndrome. And then it also is very effective at clearing autoimmune-mediated skin conditions. And so with that, I just want to highlight a few conclusions that we have here. So the first is that immune dysregulation, this occurs on a global level. It's multifactorial. This includes dysregulation in the B cell compartment, the T cell compartment, the innate immune compartment, including monocytes and lymphocytes. There's really not a component of your immune system which is not altered by an extra copy of chromosome 21. And specifically, these dysregulated immune responses can contribute to key co-occurring conditions that we see in these individuals as well. So individuals with Down syndrome have elevated rates of autoimmunity and increased susceptibility to infection. And this is likely contributed by the remodeling that we see within that immune cell compartment. So impaired memory responses, both in the T and B cells, could likely contribute to the worse outcomes and increased susceptibility to recurrent infections. Failure to suppress activation of different cell populations by the Treg cells in individuals with Down syndrome, as well as an increased propensity to have autoreactive B cells cropping up, and an increased production in autoantibodies can contribute to autoimmunity. And then the myeloid compartment also shows impaired ability to control infection through not being able to clear out bacterial particles, not being able to migrate efficiently to different sites of infection. And then with regard to interferon signaling here, what we can see is that interferon signaling in Down syndrome is elevated, and this is likely a direct consequence of having triplication of the interferon receptors on chromosome 21, which leads to hyperactive interferon signaling across essentially the whole immune compartment. Similar to what we see up here with global immune remodeling, we do see the majority of immune cells are hyperresponsive to interferon signaling, and that these elevated interferon responses modulate the immune landscape. So it's not that it's necessarily happening in tandem. There is likely a strong link between the hyperactive interferon signaling and the remodeling that we see present. And then lastly, clinical interventions targeting this elevated interferon response so far seem to be very promising. So in terms of immune-mediated skin conditions, it was very safe for treatment for these individuals. It reduced levels of inflammation. It reduced levels of autoimmunity, at least as read out through autoimmune-associated cytokines and autoantibody production. And then it cleared a lot of the skin conditions that were being targeted by this particular intervention. And so with that, I would just like to acknowledge everybody at the Linda Cernick Institute. That's the institute that I'm associated with. We're based out of the University of Colorado at the School of Medicine here. And then, of course, the Global Down Syndrome Foundation, the Include Down Syndrome Biorepository, the Human Trisome Project, which provided a lot of the samples for some of the publications that we were looking at here, DS Connect, which is the Down Syndrome Registry, and then the Include Data Coordinating Center, which helps coordinate a lot of the data generated by these Down syndrome studies here. And I would want to thank the event organizers again for giving me this opportunity to present this information.
Good morning, everybody, and welcome back to our NICER Education Camp session this morning. Thank you guys for all joining us, and thank you to our three wonderful speakers for those fantastic presentations this morning. So just to reintroduce myself, I am Kevin Lewis, and I'll be co-moderating this Q&A session with Dr. Paul Gallo. And there are multiple ways for you guys to ask questions during this session. One of the ways is to just enter your question into the chat, which Paul and I will be monitoring throughout this session. Another way is if you look at the bottom of your screen, there is a Q&A tab. You can put in your questions there. We do already have one excellent question in the chat that we'll kind of address right now. It's from Dr. Grunbaum. This is going to be for Brian. And he wanted to ask, so he said that you indicated poor memory response to vaccines for these patients, which was mostly in the adult population. Is it premature aging, or is it actually abnormal production? Or is it both of these? And we'll kind of just start off with that question.
Yeah, absolutely. So thanks for the question. I would say it seems like it's going to likely be a contribution of both, although we do see this kind of precocious aging in Down syndrome that seems to mediate a lot of what we see with immune dysregulation here. There's an aspect of it where it looks like the immune system is just aging in advance of where they typically should be in terms of their biological years. What I can say is in terms of the depleted memory B cells, we do see that really early. So it seems to be exacerbated mostly in pediatric populations, and then it starts to come closer to the typical individuals. So if I had to venture a guess, although I don't know that it's necessarily exactly well understood, I think that kind of precocious aging is maybe a little bit more of a contribution to the poor memory B cell response there.
He had some other additional questions, which included, would you recommend getting KREX in these patients?
So KREX, I know that in Down syndrome, KREX have been monitored. They've been tested via dried blood spots, for example, and it does look like they have lower rates of KREX that are detected. So I think that's definitely a possibility. I don't know that they are commonly used, though.
And then what are some of the clinical consequences, kind of probably more in response to the first part of his question?
Yeah. So, I mean, I guess clinically, I think I'd just be aware, like what you're going to have to consider here is in terms of the poor memory B cell responses, how well these individuals will do, both in terms of just recurrent infections and response to vaccinations. So I think just be aware that although they may be receiving their typical flu vaccines, they may not be as effective as actually generating these memory B cell responses that we should be seeing. And then that, of course, results in kind of more, I think we associate it more with recurrent infections. But I don't know that there's necessarily a lot of interventions that I'm seeing with relation to this memory B cell depletion. I think there was talk about in the question a component of doing IG replacement. And we do see IG therapy, but it's really not for infectious components. That's actually, there's some clinical trials out there that are looking at IG administration for Down syndrome regression disorder, which is kind of a slightly separate topic.
Okay. We'll move on to another question that I have for Dr. Lambert. You know, the thought that there are extra interferon receptors and an interferon signature makes you wonder, are they more susceptible to hyperinflammatory diseases like MAS and HLH? Is your sense from the heme side that you see more hyperinflammatory disease in these patients?
So interestingly, I don't think that hasn't been my personal clinical experience, even with our immune dysregulation team. We sometimes have a patient who has trisomy 21 and what appears to be immune dysregulation, but I don't think we've really seen very much HLH, MAS kind of hyper-inflammatory responses. In I could think of maybe one patient where we really thought and interestingly, that patient responded incredibly well to immunoglobulin, who sort of had this sort of SIRSI-like response, and was getting intermittent fevers and got immunoglobulin and got much, much better with that. So I think it isn't necessarily something that we see as far as like hyper inflammation in that sense. But I wonder if that's partly because they have a basal increased level, and it's not necessarily so much that they hyper respond to the stimulants that they get. It's that they're always responding all the time. It's sort of this tonic activation. So
I guess playing off that, Dr. Berman, do you see what's your experience with CAR T cells in these patients? Do they get worse CRS, sort of with an underlying immune dysregulation?
Thanks for the question. Can you hear me okay, Paul?
Yeah.
Yeah, so our experience, we haven't seen that. In fact, Down syndrome patients tend to do pretty well with immunotherapy, including blinatumomab for B-cell malignancies, and actually do worse with steroids. Down syndrome patients tend to crump quite a bit with steroids. So I think, CAR T-cell therapy and other immune regulatory therapy actually is fairly safe in the Downs population.
So I also have a question for Dr. Lambert. So we talked a lot about ITP in these patients and autoimmune cytopenias. How do you kind of make that decision about doing a bone marrow biopsy in a patient who presents with, especially like an isolated thrombocytopenia? Because we often will see patients who don't have Down syndrome who present with isolated thrombocytopenia, but we don't get a bone marrow. But just curious what your thought process is with regards to that.
So I think in a patient with Down syndrome with isolated thrombocytopenia, particularly thrombocytopenia in that middling range, which is where they seem to like to present, if that is persistent, if it lasts for more than a couple of weeks, then as opposed to the typical ITP kid where you might follow that platelet count for a while, I think I tend to go a little bit sooner to a bone marrow for that patient population. It's not necessarily the kid whose platelet count is 1, right? Or less than 10, especially isolated thrombocytopenia less than 10. That actually makes me think much more about ITP, but it's the kid whose count is like 40, and then the next time you see it, it's like 35, and then it's 30. I think those kids I get really worried about, and we do marrows. And there's no prize for catching leukemia early. That was something that one of my mentors taught me in fellowship, because leukemia is a systemic disease from the onset. But on the other hand, it doesn't feel good if you've been following the patient for 9 months before you finally do that first marrow, and that's when they have leukemia. But I remind myself that, like, if it is leukemia, we'll know eventually. But these kids are the kids that I go to marrow much sooner than I do. I almost never do a marrow in a patient who just has run-of-the-mill ITP.
And Dr. Berman, I see you have your hand up.
Yeah, I just wanted to add on to Michelle's response. So completely agree. And again, it depends on the age of this kid. We know that this hypothetical kid in question, and I would look at it a bit differently if it's a 6-year-old versus a 3-year-old. But we know that MLDS can very typically present with thrombocytopenia. And to Michelle's point, likely in the 40 to 50, the 60 to 70 range, not those sort of typical single-digit ITP platelet counts. And again, adding on to this issue of winning a prize for being able to diagnose leukemia early, I think that's even more so the case in MLDS, because these kids tend to have much more of a grumbling course, and whether you make the diagnosis the first week of February or the first week of March, it's going to actually do nothing in terms of changing the treatment and the outcome. And in fact, I mentioned this in my talk, and we actually saw this throughout the conduct of the 1531 trial, that kids that actually present with a viral infection and have MLDS or we want to wait and treat that viral infection. There's no rush to go to chemotherapy, which is different than, de novo AML in a non-Down syndrome patient where they have a high white count and really it's a medical emergency. So I would marrow earlier, but again, you have the luxury of time. If you're not sure and you want to wait another week, you're not going to lose any ground, and it's not going to impact your clinical outcome.
And kind of just bouncing off some of the things you guys are talking about, would you ever consider, like, with the upfront therapy, because we often will either do IVIG or we'll do steroids. Do you ever favor IVIG over steroids so that you're not masking a leukemia? Does that ever kind of play into how you kind of approach these patients?
Yeah, I mean, I think in a kid with trisomy 21 and isolated thrombocytopenia that needs to be treated, they have bleeding symptoms. I definitely will reach for IVIG before I would reach for corticosteroids. They don't tolerate steroids very well either. So as opposed to the typical kid who has a platelet count of 1 is going to get a 5-day course and they'll be fine. They might be grumpy and they may not sleep very well. Kids with trisomy 21, actually the same doses of steroids, they get gastritis and they can't eat. They get really bad insomnia or terrible behavior problems, or they get infections. And so even with the short courses, they can get sick. So I tend to try to stay away from steroids in trisomy 21 for the non-malignant indications, because I don't treat malignant disease. And just to make one more point about the bone marrows is that I will marrow a kid with isolated thrombocytopenia with trisomy 21, and I almost never do a bone marrow in a patient who has isolated thrombocytopenia outside of trisomy 21.
Dr. Berman, I see you raised your hand again.
Yeah, so just to comment on technically on the bone marrows, and I referenced this in my presentation, these can be technically really challenging in these kids, because if they tend to have, a acute megakaryoblast leukemia and tend to have fibrosis, and fibrosis is something that adult hematologists are, much more used to dealing with than pediatric hematologists. So, when you're doing that bone marrow, you really have to have, eaten your Wheaties that morning to be able to do the pull. It can be really, really technically challenging. And so it's really important to get a bone marrow biopsy. Different hospitals, different practices will, sometimes just get aspirates and not biopsies in those situations. But in the Down syndrome situation, you really always want to get a biopsy.
All right. I have plenty more questions, but please feel free to put stuff in the chat, everyone else, if you have questions. Dr. Niemeyer, has anyone looked at the CBC? I guess I'm curious about the CBCs of this big cohort you have of uh, in terms of hemoglobins and platelet counts, anemias and thrombocytopenias, and do those get better on the JAK inhibitors? Do you have
Yeah,
any?
that's a good question. So we, at least in terms of the clinical trial, we definitely have CBC data, but I don't think I think we predominantly focus more on the immunophenotyping BMS cytometry.
And I guess, has anyone looked in that big cohort at ITP, like at immune thrombocytopenia, and if it preludes other autoimmune disease?
Yeah, so I mean, I think immune thrombocytopenias. I don't know that was necessarily one of the conditions that we looked at for this. I don't think immune thrombocytopenias came up as a co-occurring condition in that particular cohort that we saw.
Yeah.
But whether or not it could modulate those effects, I think would definitely be good to check out.
And Dr. Lambert puts in the chat for you also. I would love to know your thoughts on JAK inhibitors for the autoimmune cytopenias.
Yeah, I mean, I think
Or for the leukemias, like, should we be screening? I don't know, Dr. Berman, should we be
definitely in
screening
terms of
these
I think
patients
definitely in
for?
terms of leukemias, it could have an improvement there, particularly any of the myeloblastic leukemias. So we know that interferon signaling in the hematopoietic stem population definitely dysregulates differentiation of those cell types. So there's been a lot of work looking at hyperactive interferon signaling within hematopoietic stem cells, and so that can definitely skew things more towards like myeloblast differentiation versus lymphoblasts,
Yeah,
for example.
it's hard to imagine it's not all related. Dr. Berman, do you have any experience using JAK inhibitors? And
So I don't know that anyone has necessarily experienced. We do know that there's a subset of patients with MLDS that have JAK2 mutations that confer a poor prognosis from work that's been done by our Japanese colleagues and that we've then replicated in the Children's Oncology Group cohort. And so, if a patient had a documented JAK2 mutation, though, the incidence of that probably is somewhere between 4 to 6% of patients. So it's a minority. I think they would benefit from inclusion of a JAK inhibitor, because we do know a lot about the safety profile in non-Down syndrome kids, and something to think about.
We have another question in the chat. Thank you for your questions, guys. This one, I believe, is more directed towards Dr. Lambert, but anybody is welcome to join in on this question. Regarding the use of IVIG and ITP in patients with Down syndrome, do we expect to see the same diagnostic quick response with the rise in platelets temporarily at like 24 to 42 hours, or does that time kind of vary more so with this population?
I think if they're going to respond, they tend to respond in about the same time frame, even though they have what I lovingly refer to as dumb bone marrows. They just don't seem to have a bone marrow that's normally responsive to things. But I think if they're going to respond to IVIG, they tend to respond in the same time frame, maybe not as robustly. I think that they're more likely to not respond and to have more refractory disease. At least that's been my experience, although I admit that that may also be a biased population because the trisomy 21 patients who have sort of more run-of-the-mill ITP may not be the ones that I end up seeing. But I think that I certainly have a cohort of trisomy 21 patients with pretty refractory immune thrombocytopenia. And so they may not respond to IVIG. They do respond reasonably well to rituximab. And I wonder if that's more related to their B cell differences that they have, the B cell lymphopenia, and maybe their B cells are and their abnormal vaccine responses. That may be that they really just have abnormal B cells and just get rid of them and they do better, actually.
It
but
makes
then
you
they get
wonder if
hypogam.
it makes you wonder if measuring, like getting the interferon signature, like and on those sorts of kids, and maybe even trying a JAK inhibitor if you know your type 1 interferons are through the roof.
Yeah, I mean, that's one of the things I'm going to take from this. I'm going to start looking at
That's why
that
I
a
wanted to
little
get
bit
this group
more
together.
closely.
And kind of just quickly bouncing off what you were saying, it's not, you kind of already touched on this a little bit, but do you see higher rates of chronic ITP versus kind of like the non-Down syndrome population?
I, I don't know that the frequency of development of chronic ITP is necessarily higher. I think that if they do develop chronic ITP, it tends to be more refractory. But I don't know that they're necessarily at increased risk of developing chronic ITP. I truly don't know. I don't have the data to say that one way or the other. It would be an interesting question, especially with these Down syndrome registries that we have. That might be something that's actually answerable.
Dr. Niemeyer, the last sort of question I have is why is heme metabolism so? You showed all these things, but there's always
Yeah.
heme metabolism is always hyperactive. Why is that?
Yeah, that's something that we're trying to definitely dive a little bit more into. I mean, a part of it may be, I think, maybe in Dr. Lambert's presentation early on, there was kind of a discussion about macro, just kind of dysregulation in the red blood cell population. And we definitely see that cropping up a lot, which we think is probably driving a lot of what we're actually seeing in terms of the heme metabolism signatures that we're seeing there. But that is constantly one of the elevated signatures that we see in all populations here. So understanding what's really driving that dysregulated heme metabolism signature is still a bit of a black box, but definitely of interest.
Yeah, we should meet up and talk. Okay. Kevin, did you have any more questions?
I do, and I feel bad for picking on Dr. Lambert. I feel like I'm asking her a lot of questions, but I'm very personally interested in autoimmune cytopenias. So I know we've talked a lot about ITP, and obviously anybody else can answer this as well. But thinking more about like a warm autoimmune hemolytic anemia, which we typically treat with steroids, which, as we were saying, these kiddos don't seem to respond very well to. I guess I have a couple questions with regards to it. We were already talking about bone marrowing patients with ITP in this population. Is this also a population? Because right, they're going to be on steroids, and they're going to be on steroids for a long time. Should we also be marrowing these patients? Because maybe this is their presentation is that they're presenting with like an anemia first as opposed to thrombocytopenia. Although presumably if we're diagnosing them with warm autoimmune hemolytic anemia, we already have like a positive DAT, all this other information. But I guess the question is, do these patients also not really respond well to steroids?
Yeah, I think if you have warm autoimmune hemolytic anemia and you're sure that's what's happening,
Mhm.
you have a positive GAT, you have increased reticulocyte count, you have elevated other markers of hemolysis, then I I don't necessarily worry about marrowing that patient. Theoretically, autoimmune hemolytic anemia can be a paraneoplastic thing, but it's not really something, to my knowledge, that we see related to neoplasm in Down syndrome. So I wouldn't necessarily be worried. Actually, I worry less about a hemoglobin, like a hemolytic anemia, hemoglobin of 3 or 7 in a Down syndrome patient than I do a platelet count of 25 or 30 um, for malignancy. And I'd be happy to learn if that's actually incorrect. But and then as far as their steroid responsiveness, I don't think I've only had a couple autoimmune hemolytic anemia trisomy 21 patients. We see thrombocytopenia a lot more. Um, and I think those kids didn't really get treated differently than any of the other kids. They just don't tolerate the steroids as well. So we go down on the doses a little faster.
Okay. Thank
But
you
I'd
so
be
much.
happy to hear if anybody else thinks that that's different than what they do.
And Paul, did you have any other questions you wanted to ask?
No, not really. I think I went through most of my questions.
If there are no other questions, I think we can probably wrap up today, but I just wanted to say thank you for joining us today at the Nicer Education Camp. Please join us next time for our next meeting on Wednesday, April 8th. It's going to be the Professional Development course on genetics. You can find more information at the website, nicerconsortium.org, and you can find previous camp recordings on the Nicer Consortium YouTube page. Thank you guys again, and have a great rest of your day.
Thanks, everybody. That was great.